syndromes, the important ones, and lastly the procedures employed to correct cosmetic for cosmetic correction of age-related abnormalities of the eyelid and periorbital region. First, we'll discuss about some miscellaneous acquired eyelid disorders which were not covered previously. First is the varix. We know that a varix is a dilated tortuous blood vessel or a lymphatic vessel. DD में हमारे पास nevus और hemangioma and lymphangioma आ जाएंगे. Orbital involvement may also occur if found. A varix is always compressible, subcutaneous, and bluish or purplish swelling. However, if it is thrombosed, then it is not compressible. And sometimes on performing the Valsalva maneuver, the varix becomes prominent. Otherwise, it may not be even found. As you can see, this is a subcutaneous bluish and purplish swelling. And in the picture on the right side, the upper picture shows absence of the varix, and the lower picture shows the varix becoming prominent on performing the Valsalva maneuver. The next topic is floppy eyelid syndrome. Typical age group is obese, middle age or older men. When these people sleep on their sides with their eyelids pressed against the pillow, the eyelids are constantly pulled outwards. This may lead to their sagging as well as features of exposure keratopathy. And if there is some superimposed blepharitis or dry eyes, then there will be development of chronic keratoconjunctivitis. An important association is of obstructive sleep apnea. You may found the person to be obese, having some cardiopulmonary disorders or some mental illness, and he may be having daytime sleepiness as well due to obstructive sleep apnea. Features are a lax upper lid, which is easily everted, and features of exposure keratopathy like punctate erosion, filamentary keratitis, and superior limbal vascularization. And lastly, the eyelid ptosis, lacrimal gland prolapse, and ectropion may be present. If these two are found together, like the floppy eyelid syndrome, along with the obstructive sleep apnea is found, then there has been found greater association with the development of glaucoma. For treatment, we have to treat the associated obstructive sleep apnea and lubrication of the eyelids for bedtime. Horizontal lid shortening may be done by pentagonal incision of 10 mm or more. These are the features of floppy eyelid syndrome. As you can see, the lid is very lax and it is easily everted. And due to exposure and dryness, there is the development of papillae on the tarsal conjunctiva. The third topic is blepharochalasis. It is described as recurrent episodes of painless, non-pitting edema of both upper lids. Typically involves the age group of pubertal age group, and it spontaneously resolves in a few days. Due to atrophy of the skin, there is wrinkled cigarette paper appearance, and in severe cases, it may lead to development of ptosis and lacrimal gland prolapse. A hypertrophic form and an atrophic form may be found with or without fat herniation. DDs में हमारे पास drug induced urticaria आ सकता है और angioedema आ सकता है. Treatment is blepharoplasty and correction of the associated ptosis. Whereas dermatochalasis is basically excessive skin on the upper lid. These are two different things. Here you can see some ptosis, acquired ptosis due to edematous upper lid and the eyebrow region in the left eye. Occurs usually in the puberty age span. Eyelid imbrication syndrome basically involves the overlapping of the upper lid over the lower lid. So the lashes of the lower lid irritate the tarsal conjunctiva of the upper eyelid, which may lead to formation of allergic papillae. Rose Bengal staining is positive. We know that rose Bengal stains dead and revitalized tissue, whereas fluorescein stains epithelial defects. Treatment is the horizontal lid shortening via the pentagonal incision. Now we have upper lid retraction. Retraction is said to be present if we can see the upper limbus or the sclera above it. If we cannot see the upper limbus, then there is no retraction. It is corrected by transconjunctival posterior approach, especially when no skin stretching or loss is present, or we can perform recession. For mild retraction, we will go for Muller recession, and for moderate to severe, we will go for levator aponeurosis recession. We know that these are both elevators of the lid, and recession weakens the muscle. So elevation is weakened and retraction is gone. Left lid retraction is shown in thyroid eye disease, as you can see in the above picture. And after the Muller resection, the retraction is gone in this eye. You can see the superior limbus and the sclera above it is visible. If these are not visible, then we will not say that retraction is present. Some of the causes of acquired lid retraction are mentioned. The most important is thyroid eye disease. Then there are some neurogenic causes like contralateral unilateral ptosis, third nerve misdirection, Marcus Gunn jaw winking syndrome. Mechanical causes, congenital causes, and some miscellaneous causes are mentioned. These are the important causes. Thyroid eye disease, as you can see, the eyeballs are also prominent. Secondly, there is unilateral myasthenic ptosis with contralateral lid retraction. This is the lid retraction, and this is the ptosis. This is the sun setting sign in infantile hydrocephalus. You can see in all these retractions, the superior limbus is visible and the sclera above it as well. And so, lastly, there is the picture of Parkinson's retraction. Lower lid retraction is said to be present if there is inferior sclera visible. It can be corrected by aggressive upward massaging for 2 to 3 months. Otherwise, we have to perform tarsal strip operation and inferior retractor recessions. Now we'll come to the congenital malformations of the eyelids. Epicanthic folds are basically vertical folds which are present bilaterally, and they are always extending towards the medial canthi. They can be present in either the upper lid, the lower lid, or both. Depending upon the locations, these are the names. Epicanthus tarsalis means the fold is prominent in the upper lid. Inversus means the lower lid. Palpebralis means upper and lower lid, and supraciliaris means the fold extends from the eyebrow region to the lacrimal sac. The main thing is that the folds are always extending towards the medial canthus and not elsewhere. It gives rise to pseudoisotropia. The treatment is VY or Z-plastic. As you can see, two vertical folds are there, extending from the lower lid to the medial canthus, and it is known as epicanthus inversus. Telecanthus is basically increased distance between medial canthi, specifically due to long medial canthal tendons, whereas hypertelorism means that the bony separation is large. There is no enlargement of the medial canthal tendon. Treatment is shortening and fixation of the medial canthal tendons to the anterior lacrimal crest or insertion of a transnasal suture. As you can see, the distance is increased between the medial canthi and the medial canthal tendons. These tendons are very much enlarged. The distance नहीं होता. Blepharophimosis, ptosis, and epicanthus inversus syndrome. As the name implies, it has three important features: ptosis, epicanthus inversus, and telecanthus. The ptosis found is symmetrical with poor levator function, so we have to go for sling operation. Autosomal dominant inheritance है, two types हैं इसकी, type 1 with premature ovarian failure and type 2 without premature ovarian failure. FOXL2 mutation is found. In sequence of treatment, first we have to treat the epicanthus, then telecanthus, and ultimately perform frontalis suspension for ptosis correction. As you can see, all of these have the same features, which is prominent over here. All three features are present. prominent folds extending from the lower lid to the medial canthus, yani epicanthus inversus. Hypertelorism is present, yani distance between the medial cantha is enlarged, and ptosis is present as well. This is the 5-flap technique for correction of the blepharophimosis syndrome. Multiple Z or V plus Z and Y plastics are marked in the first picture. Then incisions are made and flaps are raised. Then we reposition the medial canthal tendon with sutures or in some other techniques. And finally, the flaps are transposed, and you can see the medial sclera is now becoming more visible in the last picture. And the length of the medial canthal tendon has also decreased. And ptosis is also somewhat better. Epiblephron is extra fold of skin stretching across the anterior lid margin. There may be vertically directed lashes which turn out on pulling down the lid fold. It resolves spontaneously. Important differential is congenital entropion. It looks like entropion, but the main differentiating point is that this fold, when it is pulled down, the normal appearance of the eyelashes and the eyelid becomes visible and it stays over there. Whereas अगर entropion को आप इस तरह नीचे खींचेंगे तो वापस चला जाएगा. Now we have congenital entropion. Upper lid entropion is associated with microphthalmos, while lower lid is due to maldevelopment of inferior retractor aponeurosis. Hod's procedure basically involves excision of the strip of skin and muscle and fixation to the tarsal plate. This is a congenital entropion. If this lower lid is pulled downwards, it will ultimately go back due to elasticity. This differentiates it from the epiblephron. Coloboma. Coloboma basically may be either partial thickness or full thickness. It is basically a defect found anywhere in the eye. It develops due to embryological failure of migration of ectodermal cells, and sometimes amniotic bands may be present in the uterus or amniotic cavity, which may cut the eyelids. Why a complete ocular exam is required if you find eyelid coloboma? Coloboma कहाँ बन सकते हैं? Eye और ciliary body, optic disc. If there is a small coloboma, we will do primary lid closure, while large defects require grafting. Upper lid coloboma हमेशा middle and inner third की junction पे मिलेगा. Association में crypt ophthalmos, which will come afterwards, and golden heart syndrome. While lower lid coloboma is found at the junction of middle and outer third, and it is found in Treacher-Collins syndrome. This is an upper lid coloboma, and as mentioned earlier, usually found in the junction of middle and inner third. This is another picture of upper lid coloboma. You can see it's present on the inner side. The lower picture shows Treacher-Collins syndrome. It basically comprises of lower lid colobomas and slanting palpebral fissure and craniofacial abnormalities, as you can see over here. Palpebral fissure slanting है, coloboma है outer side पे, और craniofacial abnormalities है, and cataract may also be found. This is another picture of Treacher-Collins syndrome. Cryptophthalmos. It means absence of lids. It may either be complete, the lids may be totally absent with a covering of skin present, or rudimentary lids may be present. May be found in Fraser syndrome, which includes syndactyly and urogenital abnormalities. This shows complete cryptophthalmos. There is no presence of lids, and skin is covering the area, while a partial presence of lid is present in the picture on the right side. This is another picture of complete cryptophthalmos, and this is partial cryptophthalmos or incomplete. Euryblephron means horizontal enlargement of the palpebral fissure. It is due to lateral canthal malposition, and lateral ectopion may be present. Since the fissure is enlarged, so there are chances of exposure keratopathy and lag of thalmos, which means inability to close the eyes during sleep. You can see over here the palpebral fissure is enlarged horizontally और lateral ectropion मिल रहा है हमें और microbrephron means small eyelids. Often it is present with anophthalmos. Anophthalmos means absence of the eyeball. Ablephron means deficiency in anterior lamella. Syndrome is mentioned known as ablephron macrostomia syndrome. Basically, this is a picture of ablephron, and macrostomia means stoma means opening. Macrostomia syndrome में fish like mouth होता है और ये लोअर पिक्चर में बेसिकली ablephron की करेक्शन की हुई है और साथ fish like mouth मिलता है. Microblephron means the absence of lids. You can see there are no lids over here on lashes. Congenital eversion of upper lids is an association with Down syndrome, congenital ichthyosis. Basically, it is a skin condition which involves scaly and irritating skin. Afro-Caribbean descent may be present and it may resolve spontaneously. ये ichthyosis है, इसमें skin scaly आपको नजर आ रही है और reddish with sway itching होती है और lids everted and totally. Ankylobrephron means complete or partial fusion of the lid margins. इसमें जो कनेक्शन है उसको क्लैम्प करना होता है ताकि इस्कीमिया इंड्यूस हो जाए और थोड़ी देर बाद आपने इसको सीजर से कट कर देना होता है. Shoaib cases में underlying ocular abnormalities may be present. Ankylobrephron means the joining of the two lids, as you can see over here. This is the summary of some of the abnormalities present. The first picture shows ankylobrephron, the joining of the two lids. The second picture shows epiblephron, means a horizontal fold is present across the lower lid anteriorly. The third picture shows epicanthal folds, and the last one shows euryblephron, which is actually horizontal enlargement of the palpebral fissure and presence of a lateral ectropion. Infantile or capillary hemangioma, it may be congenital, although very rarely, but usually it is not apparent at birth. Few weeks to months में develop हो जाता है और आहिस्ता आहिस्ता within 3 to 7 years ये regress कर जाता है. Next topic is cosmetic eyelid and periocular surgery. There are some age-related changes in the periorbital region and in the eyelids and the region of eyebrows, which may include senile ptosis, ectropion or entropion, orbital fat prolapse, and wrinkling of the skin. So these techniques are usually employed to correct these changes. There may be non-surgical technique. The most popular one is Botox injection. Botox का effect temporary होता है and lag of thermos develop हो सकता है, ectropion और diplopia इसकी वजह से हो सकता है. Secondly, tissue fillers हम use कर सकते हैं. Hyaluronic acid, we know it is a very important component of the extracellular matrix, but its effects are usually temporary for 3 to 12 months. It is injected deep into the orbicularis. Secondly, we can use autologous fat, which has a more long-lasting effect. And thirdly, we can use collagen or microsphere implants. Thirdly, the resurfacing of the skin may be done. We may use laser or chemicals to cut the skin, and so the new skin which regrows is more even in appearance. Surgical techniques may also be employed. The number one is the upper lid blepharoplasty. This is mostly important in cases of dermatochalasis, which involves the presence of extra tissue in the upper eyelids. So the excess skin is removed in this procedure. Complications may be if firstly we may have exposure keratopathy, lag of thalmos, and secondly if we remove too much of the tissue, then it may give an unsightly appearance. The eye may appear to be sunken in due to overcorrection. Lower lid blepharoplasty may be done for lower lid changes, which include excess tissue in the lower lid or orbital fat prolapse in the region of the lower lid. Anterior approach is employed when there is excess skin, and posterior transconjunctival approach is employed when there is no excess skin or lid laxity. You can see dermatochalasis. ये एक्सेस टिश्यू है अपर लिड में लेफ्ट साइड पे, जिसकी वजह से सूडोटोसिस और मैकेनिकल टोसिस हो जाता है, और ब्लेफरोप्लास्टी के बाद ये सारा प्रॉब्लम करेक्ट हुआ हुआ। और लेफ्ट द इमेज ऑन द राइट shows severe dermatolysis and the next picture shows correction. We have already covered the topic of brow ptosis. It may be corrected by using two approaches: direct brow lift or endoscopic brow lift. In direct brow lift, the skin above the eyebrows is incised, the tissue is removed, and the suturing is done, so the brow is lifted upwards. Secondly, in the endoscopic approach, we make small incisions in the hairline and pass endoscopes to visualize the forehead tissue. And correction and pulling of the forehead tissues is done via the endoscope. Now we'll come to the MCQs. Which of the following surgical procedures is likely to be most efficacious for the following scenario? A 2-year-old girl presents with bilateral ptosis with obstruction of both visual axes. Her eyes are set far apart. Her father has similar features. A. Aponeurotic repair. B. Frontalis suspension with silicone rods. C. Levator resection. And D. Frontalis suspension with facial sling. आंसर इसका बी है, सिलिकॉन रॉड्स यूज करते हैं। बेसिकली टू ओपिनियन है इसके बारे में कि 3 year old से नीचे नीचे अगर बच्चा है तो उसमें फेशियल एटा पूरी तरह डेवलप नहीं हुआ होता, तो हम उसकी जगह सिलिकॉन रॉड्स यूज करते हैं। लेकिन एक ओपिनियन ये भी कहता है कि हम फेशियल एटा भी यूज कर सकते हैं। थैंक यू।
हाँ, ये आखिरी स्लाइड एमसीक्यू की जरा दोबारा दिखा दे। ओके, सो बैठ एक दफा जो हम मिस्टेक पॉइंट आउट करते हैं ना, तो कोशिश करें अगली दफा वो ना हो। कोई नई मिस्टेक कर ले कोई बात नहीं, लेकिन वही दोबारा ना रिपीट करें। ये एमसीक्यू में एक तो 4 ऑप्शन हैं, मैंने आपको कहा था कि 5 ऑप्शन होनी चाहिए, तो एक ऑप्शन अपनी तरफ से लिख लें, कोई लफ्ज ही लिखना है ना एक। और दूसरा ये अल्फाबेटिकल ऑर्डर में नहीं है। पहला है एपोन्यूरोटिक टोसिस, दूसरा है फ्रंटालिस सस्पेंशन, थर्ड है लिवेटर, और फोर्थ है फिर फ्रंटालिस। तो इसको अरेंज करें अल्फाबेटिकल ऑर्डर में। कैसे करेंगे रे? पहले ए आएगा, फिर उसके बाद 2 एफ आएंगे, फिर एल आएगा। ठीक है, तो ये एमसीक्यू में ऑप्शंस आपकी हमेशा होनी चाहिए अल्फाबेटिकल ऑर्डर में। जो टॉपिक आज लिड एबनॉर्मेलिटीज कवर किया, उसमें व्हाट इज द नॉर्मल साइज ऑफ द लिड, अपर लिड और लोअर लिड। आप कहते हैं ये छोटी लिड है, ये बड़ी लिड है, कोई स्टैंडर्ड तो होगा। 30 millimeter, good. So normal size of the lid is 30 millimeter. What is the distance between the two medial canthi, intercanthal distance? आप कहते हैं ये कम है, ये ज्यादा है। 30 millimeter. So distance between two medial canthi is 30 millimeter. If it is more than 45 millimeter, तो फिर आप इसे क्या कहते हैं? टेलीकैंथल। और हाइपरटिलोरिज्म कब कहते हैं? जब दोनों आई बॉल्स या आई ऑर्बिट्स के दरमियान में डिस्टेंस ज्यादा होगा। तो व्हाट इज द नॉर्मल डिस्टेंस बिटवीन द टू प्यूपल? इंटरप्यूपलरी डिस्टेंस क्या होता है? 60 millimeter. So roughly 60 millimeter is the normal interpupillary distance. So if it is more than 60 millimeter, it means the two pupils are apart, means two orbits are separated more than normal. So this will be called hypertelorism. So when we correct the telecanthus, we shorten the medial canthal ligament so that the medial canthi are pulled inwards towards the midline, and we correct the epicanthus with double Z plastic. यहाँ पे हमने बहुत सारे ऑपरेशन किए हैं, वो मुझे अब बताते तो मैं वो भी फोटोग्राफ आपको दिखाया था. So we make two Z on each side, up and down, and we correct it. This is called, the simpler procedure is YV plastic. This double Z plastic takes a little bit more time, but it's more cosmetically rewarded. So this is about telecanthus. और आपने क्या डिस्कस किया जो करेक्शन? So dermatocalasis, we do blepharoplasty, we remove the extra skin. So how much should be the distance between the lower margin of the eyebrow and the eyelash? कितना distance होना चाहिए minimum? आप कहते हैं ये एक्स्ट्रा स्किन रिमूव कर दें, एक्स्ट्रा तो रिमूव कर दिए तो बाकी कितना रह जाएगा? So 20 millimeter is the minimum you should leave the distance between the lower margin of the eyebrow and the eyelash. अगर इससे कम रहेगा तो क्या होगा? लैग ऑफ थैलमोस, आई कंप्लीटली बंद ही नहीं हुई. ठीक है, तो जब हम ब्लेफरोप्लास्टी करने लगते हैं तो वी पिंच द स्किन बिलो द आईब्रो and see whether the eye closes or not. कल फिशर खत्म होता है, eyelid complete closure होता है कि नहीं होता है. अगर आपने पिंच किया और eyelid close नहीं हो रही, इसका मतलब आपने ज्यादा पिंच कर, थोड़ा सा रिलीज कर रही. So we don't want to produce lag of thalmos. What about और कौन से प्रोसीजर आपने डिस्कस किए? लोअर लिफ्ट, ब्रॉड लिफ्ट हमने किए. So you excise elliptical tissue above the eyebrow so that the eyebrow is lifted up. This usually is encountered in facial nerve palsy. There is brow ptosis as well as the paralysis of the facial muscles. So direct brow elevation तो हमने किए हैं यहाँ पे. So एंडोस्कोपिक हमने नहीं किए यहाँ पे, उसके लिए एंडोस्कोप रिक्वायर होती है, वो वाली हमारे पास नहीं. So we do direct brow elevation lifting. और you see, when you do blepharoplasty, you are excising the skin below the eyebrow. अगर आप ज्यादा कर देंगे तो ब्रो भी नीचे आ जाएगी, ब्रो टॉसिस भी हो सकता है. So before doing blepharoplasty, you make sure that there is no brow ptosis. और ये जो मैं बार बार कहता हूँ ना, इतने हमारे पास पेशेंट्स हैं, रोज के 1200 पेशेंट आ रहे हैं, तो सारी फोटोग्राफ जो है ना वो हम किताबों से सामने निकालते हैं. तो ये मुझे मतलब अच्छा नहीं लगता. आपके पास ओपीडी में पेशेंट कितने केसेस आपने देखे होंगे ये एपिकेंथस के और ब्लेफरोफाइमोसिस के, फोटोग्राफ उतारें और ग्रुप में शेयर कर दें, इसी तरह पूल बनेगा. तो एवरीबडी शुड हैव ओन फोटोज एल्बम पूरा होना चाहिए आपके पास, ये एकेडमिक का, राइट. तो अभी आपने शुरू किया, आयजा ने एक वो किसने पिक्चर किसने उतारी थी जो सुपीरियर हैप्टिक, नेहा. और लेकिन ये है कि देखें, न सिर्फ फोटोग्राफ उतारना जरूरी है बल्कि उसको स्प्रेड करना भी जरूरी है ताकि कल को वो आपके काम आएगी. तो बाहर के मुल्कों में तो वो या आर्टिकल पब्लिश करते हैं या पेपर प्रेजेंट करते हैं, इससे डिसेमिनेशन होती है, दूसरों को पता चलता है अच्छा आपने वो केस देखा हुआ. अब तो व्हाट्सएप ग्रुप है, फोटोग्राफ उतारे और उसमें ग्रुप में डाल दें, और नहीं तो 2-4 लोगों के पास सेव हो जाए। ठीक है, ओके, थैंक यू वेरी मच।
अच्छा, इसमें ये करें कि आप लोग सारे लोग हैं एक एक टॉपिक पकड़ लें। फॉर एग्जाम्पल एक लिड की कलेक्ट करता जाए, जो कोई भी है वो, इसमें एल्बम बनाने में आसानी रहेगी। और ये है कि अपने इंटरेस्ट को देखते हुए कोई भी तस्वीर हो वो उसके पास आ रहा है, ताकि वो कलेक्शन जब भी आपको जरूरत हो गई लिड की चाहिए तो आप उस पर्सन से कांटेक्ट कर सकते हैं। दैट शुड बी सेट टाइम। ठीक है। दूसरी बात ये कि 30 मिलीमीटर, अभी 30 मिलीमीटर की है, 30 मिलीमीटर एक और मेजरमेंट भी है जो कि उसकी भी नेक्स्ट एक टर्म होगी इलेक्ट्रॉन, वो आप कैसे कर सकते हैं?
जो हमारी लोअर जैसे थोड़ी
Anyone else? We all. We have to left on mostly books.